Thank you all for joining us this evening to learn more about Johns Hopkins Global Neurology and its Zambia program. I'm Justin McArthur, Director of the Department of Neurology and Neurologist-in-Chief for Johns Hopkins Hospital, and I'm humbled to welcome so many old friends and new to an evening of dynamic conversation with leaders in the field of global health, medical education, neuroimmunology, and stroke. Tonight, you'll hear from 3 Johns Hopkins neurology experts, faculty leaders, Deanna Saylor, who's the founding director of our Zambia program, and a neuroinfectious disease and neuroimmunology specialist. Argye Hillis, who serves as director for our Center of Excellence in Stroke Detection and Diagnosis for the Sheikh Khalifa Stroke Institute. And finally, Victor Urrutia, who directs the Sheikh Khalifa Stroke Institute. I have the great pleasure of working with all 3 of these experts almost daily, and I can confidently say that I cannot think of a better team to stand up Sub-Saharan Africa's first neurological training program and Zambia's first dedicated stroke unit. You might be wondering, why Zambia? How does work being done thousands and thousands of miles away on another continent inform my care here in Baltimore, Washington, or elsewhere in the States? Or why is this even a priority? Well, tonight we will aim to address these topics and more. And I'll kick things off by sharing why our work in Sub-Saharan Africa is important to me and to the field of neurological care. I believe that the program that you'll hear about tonight is one of the most impactful that our department has ever developed. It ties directly into Johns Hopkins' mission, knowledge for the world. I've known Deanna Saylor since she was a medical student here at Hopkins, and she then successfully completed a neurology residency followed by a neuroinfectious disease fellowship. Her interest in global neurology was sparked during a student elective in Kenya. After she joined our faculty, she and her family, her husband Brad, children Emma and Owen, made the commitment to move full-time to Lusaka to direct the fledgling neurology residency program there. In the spirit of Hopkins' tripartite mission, Deanna has substantially grown the educational program and added NIH-funded research, both added to the outstanding clinical care that she and her team provide daily. My wife Julie and I were privileged to visit them there earlier this year, and we saw just how important clinical skills are in an under-resourced environment. We also sensed the excitement amongst the team in being able to expand into the project that we will share with you tonight. I have unlimited confidence in her ability to lead this project to completion. She has vision, dedication, and passion, as you will see and hear tonight. So one final and important item before we get started. There will be dedicated time for audience questions. So throughout the program, please type yours in the Q&A feature in Zoom. We want to hear from you. So my ask to you is this. As you listen and learn, I humbly request that you do so while also considering how you might plug in, how you can be helpful in a philanthropic sense, and also how you can leverage your network of friends and colleagues to introduce us to others who, like you, may be passionate about global health, health disparities, access to specialty neurological care, and training the next generation of neurologists. Now, without further ado, I am pleased to introduce Dr. Deanna Saylor to kick off tonight's program. Deanna?
Thank you so much, Justin, and thank you to all of you for taking time out of your busy schedules during this holiday season to join us tonight. I'm really grateful and honored to be able to talk to you about the work that we're doing in Zambia through the Johns Hopkins Global Neurology Program. I first developed my interest in global health as a medical student. I was lucky to be at Hopkins and encountered physicians from all over the world who came to Hopkins to do some of their training. And I decided that I wanted to know what global health was like. And so as a student, I was able to travel to Kapsawar, Kenya, where I did a 6-week internal medicine rotation. And this really sparked my passion for global health. It was in Kapsawar where I saw poverty and need on a scale I had never encountered before, and realized that I could make a huge impact in this field. And so I came back from that experience thinking about dedicating my career to global health, but also very aware that in 6 weeks I was still very much in the honeymoon period of being abroad. And so I decided to take a year out from medical school and travel back to Kenya, this time to Kisumu, where I spent a year doing neuro-HIV research. This time it was a bit different. Kapsawar had been a village of about 500 people in western Kenya. Kisumu is the third largest city in Kenya, but we still traveled out to small villages. You can see in the bottom right, this was our research setup. We would pitch tents and have folding chairs and cots where we would do our research. And I spent about 18 months in Kenya that year, and this really confirmed my passion for and commitment to global health and global health research. And then I was lucky enough, after I finished medical school here at Hopkins, to join the neurology residency program here, and was able to become involved in a research project with one of our faculty in Uganda. And I was able to go to Uganda 3 times as a resident to contribute to that work. All of these experiences were really impactful to me. And I'm a researcher, I love research, but I also recognized from these experiences that there were almost no neurologists in these countries, and that one way to make a sustainable and impactful difference for neurology in sub-Saharan Africa would be to lead a training program and train neurologists and train people to become neurologists in their home countries. And I was lucky enough to get a Fulbright Award from the US State Department that allowed me to do just that. And so in 2018, my family and I, you can see I had a 4-month-old and a 2.5-year-old at the time. We sold our house, we sold our cars, and we moved to Zambia. And we've been living in Lusaka, Zambia, for the past 6 years, where I've been based at the University Teaching Hospital. During this time, I founded the Johns Hopkins Global Neurology Program that aims to bring together global health and neurology expertise from across the university and really contribute to that tripartite mission of Johns Hopkins of improving neurology education, neurology clinical care, and contributing to neurology knowledge through research in global health settings. And the Zambia project is really the cornerstone of this program. We haven't done it by ourselves. We've been working with partners from the University of Rochester, as well as Beth Israel Deaconess Medical Center, who also have faculty based in Zambia. But through this program, I've led the development of Zambia's first neurology training program and inpatient service in Zambia. So when I arrived at UTH in 2018, there were no Zambian neurologists in the country. The entirety of neurologic care for this country of 20 million people was provided by 3 expatriate neurologists who primarily were dedicated to research. They had an afternoon clinic 1 day a week, and an EEG and EMG lab had been established, but there was no neurologist actually working in the hospital. And so the first thing that I did in 2018 was to establish an inpatient neurology unit. And then shortly thereafter, we began a neurology residency program, training the first neurologists in Zambia. You can see here in this picture the outside of the medical wards at our hospital. These are big open wards that are sort of subdivided into small bays. And you can see inside a ward there, we have some curtains that we can draw down to try to give patients a little bit of privacy, but essentially we care for lots of patients in a small space and with very limited resources. But despite the challenges, we've had a lot of success. So in the past 6 years, we've trained 9 neurologists, 7 adult neurologists, 2 pediatric neurologists, and most exciting, I think, is we actually have 10 more in training. So within the next 2 years, we'll graduate an additional 10 neurologists, bringing the total to 19 neurologists. We've increased access to specialty neurologic care, both in the inpatient and outpatient setting. And we're actually the second busiest service in the hospital because there's such a high burden of neurological disease. In addition, we've worked with partners in the private sector in Zambia to develop teleneurology programs so that patients in remote areas can actually access our specialists in Lusaka. And I've been working to lead a robust clinical research program that focuses on a variety of diseases. So we have projects in multiple sclerosis, in infections of the brain, in Parkinson's disease, and in epilepsy. But really the cornerstone of the work that we've been doing is around improving stroke care and stroke outcomes. So just to give a little bit of a pictorial view of how much our program has grown, this is a picture of the first day of neurology training in 2018 with our first 5 trainees. By 2021, in the top right here, you can see that we had an expanding neurology family. And then this is a picture in the bottom that was taken at the graduation of our neurologists in 2022. So we've really grown the trainees, the graduates, there's research coordinators in this, there's medical students who are interested in going into neurology, and it's just been really exciting to see the neurology program expand so much in such a short time. And recently, we've had a lot of really exciting developments. So our last 2 graduates were posted by the Zambian government to hospitals outside of Lusaka. And so we have neurology units that are now starting at provincial hospitals across the country. The 3 graduates who will graduate in January will also be posted to other provincial hospitals, so we can start improving access to specialty neurologic care outside of the capital city. During COVID, we also, just like everyone else, converted to a lot of remote opportunities, and we took this opportunity to leverage the remote Zoom-based lectures that we were giving to our residents and expanded them to learners from across sub-Saharan Africa. So we now have neurology residents, internal medicine residents, medical students from Ghana, from Nigeria, from Uganda, Kenya, Tanzania, who join us every day to learn from our curriculum. As I mentioned, we've spent a lot of time developing our clinical research program and have ongoing studies focused especially around stroke. And we've really been building critical momentum to continue to expand the impact of our program. And in particular, I'm very excited about 3 unique opportunities. So the first is that this year, 2 of our trainees are actually international trainees. So the picture on the left is Dr. Leroy Yankee. He's an internal medicine physician from Liberia who's completing his neurology training with us. When he finishes training in about a year, he'll return to Liberia, where there are currently no neurologists in the entire country. So he'll be the first neurologist in Liberia, and we're looking forward to supporting him to develop a neurology training program in Liberia so that they too can have a developing neurology program. On the right, you see Dr. David Nasoro. He's a Tanzanian physician. Tanzania does have some neurologists based in their capital city of Dar es Salaam, but David is from the Southern Highlands region of Tanzania, where there's 19 million people and no neurologists. So his university has sent him to Zambia to train, and when he returns, he'll begin a neurology training program at his university that hopefully will build more neurologists in that part of Tanzania as well. We're excited to continue this and to continue to have a regional impact. We have physicians from Uganda, Ethiopia, and Eritrea who would all like to come and train with us. We're just a bit limited in how we can support their salaries when they come, but we really are looking forward to the opportunity to train others and help to support neurology training programs in other countries. In addition, our site has become well known for people who are interested in gaining more experience and training in global neurology. And so we have students, residents, fellows, and faculty from across the world come and spend time with us doing clinical electives. We currently have a fellow from Germany. We have a fellow who will come next year from Ireland. We have a fellow from Canada there now. We have residents, 2 residents from Johns Hopkins who are in Zambia right now doing clinical electives. And these experiences really allow them to learn how to practice neurology in a resource-constrained setting and how to train others in that setting as well. And then finally, just last month, we launched Zambia's first ever stroke research or stroke unit. So this is a clinical unit that's dedicated to improving care and outcomes for patients with stroke. My research in Zambia has shown that 50% of the patients admitted to our clinical service have stroke. And before we started the neurology training program, there was a 44% in-hospital mortality for patients with stroke. Just by starting the neurology training program and training specialists in stroke care, we cut that mortality in half. It's now about 25%, but we still thought this was an unacceptably high rate. And so we decided to train Zambia's first ever stroke nurses and start a stroke unit. Currently, we are housing this stroke unit in a small corner of the internal medicine ward space, but the hospital has been really excited by this work. And just like at Hopkins, space is a premium at our hospital and in Zambia as well, but the administration really believes in our vision, and they have given us dedicated space to develop a stroke unit. But this space has not been used in about 10 years, and as you can see from the pictures, requires significant renovation. But we have a vision to make this an excellent stroke unit, but also a larger neuroscience institute that includes training space for our residents, faculty offices for our graduates, new EEG and EMG rooms, new clinical space. And also this unit that we've been given, there's a courtyard outside of that unit, and the hospital hopes that eventually we'll be able to expand further, and build a new neurology institute. So thank you for letting me share more about our vision. And I'm excited that I have two experts in stroke care here, with Argye Hillis and Victor Urrutia. And so, Argye and Victor, to kick off our discussion, I wonder if you might briefly share a bit about your experiences in Zambia, since both of you have been able to come visit. Argye, would you kick us off?
Sure. So I have really enjoyed my time in Zambia. I've gone every year for a couple of weeks to participate in the training program, and I've seen it grow so much from met the very first trainees, and at that time there was really only Deanna full-time as attending, and then the initial 4 trainees, and then we couldn't see all the patients every day. We had to see men on one day, women the next day. And now with the ones who have graduated and have become tremendous attendings and who are teaching the new residents and trainees, we are able to see patients every day. One of them told me that Deanna really provided a model for the entire hospital on how attendings should teach people and provide care. So he said, usually here, the consultants come by and they put a few notes in the chart about how to take care of the patient, and they never come back. And Deanna, and so the residents or trainees learn that's how you take care of patients. And Deanna taught them, no, you really have to figure out what their problem is. You have to order tests and come and follow up on those, look at the scans yourself, come back and see if they responded to the treatment you recommended, and make sure when they leave the hospital that they come to clinic. Clinic is one of the most interesting parts of my visit there, when I see patients coming back with all kinds of conditions. Sometimes they've never been in the hospital, sometimes they are hospital follow-ups, but they have the variety of problems that we see here, plus many other infectious diseases, nutritional deficiencies, and so on that we don't see here. A lot of parasitic infections in the brain and so on, a lot of complications of TB. So I've learned a tremendous amount by being there, and I've also just had the joy of seeing the program expand each year to become better, and for us to be able to do more and more effective treatment each year.
Thank you. I had the opportunity to visit Lusaka a couple years ago, and I went there to look at the resources available for stroke care, and I was very impressed, one, with the tremendous need for the basic resources to take care of stroke patients. But at the same time, was very impressed by the heroic work and the tremendous leadership that Deanna has shown in the hospital. I met with every department's representative and lead, and that was all organized by Deanna, who asked them to come, and we talked about what they had to be able to take care of stroke patients. I also met with the residents, which I thought was a tremendous group of very smart people and dedicated, excited to learn, excited to be neurologists. And the impact of that is tremendous. I think, as Argye said, the leading by example and learning how to practice medicine in a humane and complete way, it's really a tremendous benefit to the country.
Thank you both for that. Argye, maybe we can talk for a minute. In general terms, what is stroke?
So a stroke occurs when not enough blood carrying oxygen and glucose can get to a part of the brain, and so that part of the brain dies. And there are two basic kinds of stroke. One is where the vessel bursts, so it can't carry blood to the cells that need it. And the more common kind is when there's a clot that stops blood flow in the brain. And that causes permanent damage. But the damage doesn't always occur all at once. So the symptoms occur all at once, but some of that is because there's part of the brain that's not getting enough blood flow, but it hasn't died yet. So the most important ways to treat stroke are to limit the amount of damage and actually recover function by restoring blood flow when we can. So we have clot busters and various interventions to try to increase blood flow.
And how has our knowledge of stroke changed over the last several decades?
Do you want me to continue?
Yep.
Sure. So it's changed a tremendous amount, partly on the basis of imaging, advanced imaging. So MRI has helped us understand the evolution of a stroke, that it doesn't really occur all at once, that it can be the progression or expansion of the damage can be halted or even reversed at times. And we have learned new ways of getting blood flow to the brain. We've also learned new ways to prevent stroke. So things like statins are very important, and blood pressure control. We've learned that you have to control it more strongly than we used to think. We understand some new mechanisms of stroke in terms of inflammatory conditions, dissections, lots of things that can cause this type of damage to the brain.
And maybe one final question before we move to Victor. Who are the populations across the globe now that are most impacted by stroke?
So it turns out almost everyone is vulnerable to stroke. So according to the World Stroke Association, Stroke Organization, 1 in 4 people in the world has a stroke at some point in their life. However, it's only 1 in 5 in the United States. The most vulnerable populations are people who have risk factors like high blood pressure, which is very common in Zambia and in sub-Saharan Africa, diabetes, smoking, and poor diet, as well as reduced level of exercise can all be risk factors for stroke. So those are the people most vulnerable. Most people think men are more vulnerable than women, but it's really about equal. And the reason it's such a big problem in Zambia is because there are so few resources. Not everyone has access to good food, nutrition, much less the medications they need to keep their blood pressure under control. Certainly one of the big advances there was the National Health Insurance, which started a few years into when I was there, and so we can actually expect people to refill their medications after they leave the hospital. But there's also decreases in resources currently, like things to prevent clots after stroke, sequential compression devices, and certainly imaging has been a great limitation in Zambia. We often have to wait a month to get a CT scan, which makes it challenging to treat somebody because you don't know if it's the bleeding kind, the hemorrhage type of stroke versus a clot in the brain. So that can be very challenging. But we have some ideas for how to meet that challenge, and we'll talk about that later.
Victor, can you talk a little bit about some of the recent advances in diagnosing and treating stroke?
Yes, most of the advances that have occurred so far are in the area of imaging and fast diagnosis of stroke, different types of software and machine learning assisted imaging protocols and software, MRI devices, and actually we're going to have a demonstration of an advancement in terms of the making an MRI smaller and more portable. There's also advances in treatment, and we have new drugs that function as clot-busting medications. We have surgical treatments which are catheter-based to extract the clots from the arteries that are being blocked, and also surgical procedures for other complications that arise in stroke patients. And we are now also really entering an era where a lot of work, a lot of research and discoveries are being made in early recovery and recovery of stroke deficits, as well as not only the recovery of the function and the adaptation to the daily activities, but actually recovery of the deficits. And I think that's going to be a really big area of improvement in the future, in the near future.
There's certainly been a lot of advancements already made. What are the current challenges still remaining in the diagnosis and treatment of stroke, maybe both here in the U.S. and also internationally?
Right. So I like to say that the biggest challenge right now is I mentioned the recovery part, which is something that has become the leading edge of the research. But I think that the biggest challenge, still in the U.S., but also in the world, maybe more so in the world, is getting access for patients to all these treatments and diagnostic studies that we're talking about. And I think it's really important to recognize that probably the most effective way of giving that access is the development of the stroke unit or stroke center. In North America and Europe, you can see a very clear correlation between the development of the stroke centers and the access to the intravenous clot-busting medicine and catheter-based therapies. Same thing in Europe, same thing in Australia. But a lot of the world, especially low and middle-income countries, don't have access to that kind of center. Now, interestingly, this is not that hard to do, but it requires resources. And one of the biggest arguments for developing I mentioned the access, but also that by creating the stroke unit or the stroke center, you have a concentrated group of experts at the physician level, nursing level, staff level, and the stroke center or unit also spills out to the community in terms of prevention in the community, awareness, pre-hospital care, and returning those patients to the community with a better functional state. Studies have shown that the stroke unit as a treatment, if you could imagine that the stroke unit is like a pill, is as effective as the modern clot-busting medicine treatments, and it's available to more people. And the last thing that I would say about this point is that I have seen personally in countries where you organize a well-functioning stroke center, that spills over to other hospitals, and sometimes, even if you do a project in one hospital and demonstrate the efficacy and how the stroke care improves, that's when the governments then take the idea and decide to put in the resources that they haven't put in before to spread this benefit to the rest of the population. So I would say, for example, in Zambia, that this could be the proof of principle project that would lead to the government in Zambia to devote a greater share of resources for stroke patients elsewhere in the country.
Thanks, Victor. And it's interesting, we've had our stroke unit there open for 6 weeks, and we've already had 2 patients from private hospitals actually asked to be transferred to our hospital, which is much less resourced than the private hospitals. And now the private hospitals are already asking, can we help them to support stroke units there? So maybe just kind of coming back to Zambia and wrapping up this portion before we take questions from those of you online. As you think about yourself as a neurologist in general, how do you change your approach to diagnosing and treating patients with neurological disorders like stroke and other problems when you come to Zambia or other similar settings?
So one of the things that's really remarkable in Zambia is how much you involve the family in treating the patients. So here we have lots of nurses, so each nurse only has a couple of patients. There are many more doctors per patient as well, but there are fewer nurses for a lot more patients, and so the families are asked to actually bring in food for the patient, feed the patient, change the patient, do the exercises they need to help the patient recover. And we can learn from that. It is great to have family and friends involved, and that's been very effective and encouraging. I know we think we have to do things with a lot less information sometimes, so we have learned we don't really have to get blood tests every day. We have minimal imaging right now and so on. So it's a little bit different approach, still based on just the history and exam, the most important part of diagnosing for a neurologist, and then caring for the patient.
Yes, I think that's the key, is that you need to, it really enhances your clinical skills. You need to be more clinical. You need to think harder. What is the test that is going to give you the most amount of information that you need, because you don't have the option to order a test for every specific thing. And then you need to tie those dots together to get the picture of what is happening with the patient and what is going to be the best treatment. And the other thing that I think is, and this is actually something that is exciting, because Deanna and her team is going to be, they're going to be the groups of people that are going to really develop what other options for treatment are there that are not the same options that we have here, because the resources, even when they get enhanced, are not going to be the same everywhere. And there's a spectrum of treatments and diagnostic procedures that that work or may work, and is groups like Deanna's that are going to actually do that find out what are the tests, the treatments that can help these patients in these scenarios. And I think that the other aspects, and going back to the stroke unit, is that when you have very limited choices of the test that you want to do, you can actually determine, with knowledge of your patient population, the characteristics of your patients, and the expected diagnosis that you're going to see, you can create the protocols that drive the stroke unit to use the specific tests, so that you don't have to repeat tests, but get the right test at the right time in every patient, and that also is something that the stroke unit helps with.
Yeah, I think you both have kind of encapsulated my thoughts on this as well. You know, I think the way we practice neurology in Zambia is really neurology in its purest form. You know, we don't get the benefit of relying on as many investigations, and so it's you and the patient, your history and your exam, and having to think, you know, and apply clinical rationale and really think about your use of resources. And when I come back here and attend at Hopkins, I often talk to the residents and say, well, why are we ordering that test? You know, is it really what we're thinking? And do we really need to order that test? Because sometimes we practice here in the US as if we have unlimited resources, but we all know that our healthcare costs are too much here in the US, and being a bit more rational and thinking clinically about patients, I think, is important anywhere, not just in Zambia. And it looks like we have a question about, you know, what we can learn in Africa that translates to the U.S. And I think that's one thing. There's also been really impactful clinical trials done in sub-Saharan Africa. Actually, one took place at our hospital in Zambia, looking at treatment of a particular type of meningitis. And the trial was initially designed to say, well, when you don't have all the resources available in a high-income setting, what's the best alternative? But in fact, they found that one of those alternatives was better than the standard practice in the US. And so it didn't just inform practice in Africa, it changed practice everywhere across the world to know that there was actually a less expensive regimen that did better than the expensive one we were using. And so I think that, again, having to practice within resource constraints can not only inform practice there, but also here. I don't know if you guys have other thoughts on how the practice in Africa could potentially inform care here as well.
Well, I think that the example that you gave, it's definitely one of the main aspects of it. I think that the other aspect is what you're already doing, which is having residents from here go there, because that experience enhances their abilities when they come back. And we also have areas where we have low resources in the U.S. and in Europe, and some of the skills and treatments, procedures that work there might help us deal with some of those disparities and challenges in low resource areas in this country. So I think there is definitely a mutual benefit to this.
I absolutely agree. I think we also see some things in Zambia that we can translate to the United States in terms of the interaction between, say, infectious disease or nutritional deficiencies and stroke, and how that can actually affect stroke outcome if we address some of the other underlying or comorbidities. So I think that's one thing I've learned as well.
Yeah, and I think too, your comment about the residents coming, you know, with more and more global movement of people, we are seeing these rare conditions in the U.S. We see them more and more in immigrants or people traveling to the U.S. And so having exposure to those less common conditions allows us to take better care of those populations here in the U.S. as well. So, just a reminder to those of you online, if you have questions, please do type them into the question and answer box. And, I think as the scope of this work and our impact grows, people are wondering, what is the business model for making neurological care more accessible and affordable to Zambians, especially the poorest populations? I think we have been working on that. Our hospital is a public hospital. It's a government-run hospital. It really serves the most vulnerable populations in the country. So 75% of our patients live on less than $1 a day. So that's the extreme poverty level. Patients with a lot more money will go to private hospitals rather than come to UTH. And so, the National Health Insurance Scheme in Zambia has helped, but we're really looking at practical, low-cost solutions that can improve care and inform our practice. We have a question about public-private partnership or other parties besides the government. And maybe, Victor, you can talk about some of your work in other countries.
I wanted to add about what you were saying in terms of the business model. I think that it definitely is going to take resources from the government. For example, they have a national health insurance. But sometimes, I would say often, based on my experience in other countries, the authorities, the leaders just can't imagine that you could treat stroke or you could do a protocol or a specific procedure or diagnostic test because they think is the stuff of science fiction. And by having this program that demonstrates that with the people there, with the resources that are present currently, you can actually have a dramatic improvement in the care and the survival and the recovery of these patients. That spurs the government to then support this going forward. So I think that it's actually an investment in demonstrating that it can be done so that the governments can assign resources to it. Governments don't want to invest in things that they think are time limited or that are not going to work. So by demonstrating it, it's really a powerful way of changing the way that the healthcare is funded and delivered in the country.
There's a question, why Zambia over other African countries with the same patient risk factors and the same dramatic needs? This is a great question. Honestly, it was an opportunity when I was looking to do work abroad and really knowing that I felt like the best way to make a long-term impact in a country was to start a training program. There were these US-based neurologists who had a presence in Zambia. They'd been there doing neurological research, and they made me aware that the Ministry of Health in Zambia was wanting to prioritize specialist training in the country, and we're really open to having a neurology training program. Personally, again, I was moving my family with young kids there, and Zambia is a stable country, a safe country, and so it seemed like the right opportunity, but absolutely the need is not limited to Zambia. And I think that's one of the reasons I'm so excited about the opportunity to have international trainees train with us, because we really can see the impact of our program in Zambia, not just within Zambia, but really across the sub-Saharan African region, and being able to support other clinical programs, but also especially other neurology training programs to really see this lasting, locally sustained impact is really, really exciting. Go ahead, Argye.
And just one thing that Deanna mentioned earlier, but I think it's really impacted the entire sub-Saharan Africa continent, is that they have a teaching program every single day, so residents and other trainees have lectures. Many of these are provided by us. I continue to teach even when I'm here in the United States, and many of the other Hopkins faculty do. And those are really listened to by people in trainees in all of the other African countries, and I think that has made a tremendous impact.
There's actually a neurology training program in Nigeria that has made our virtual curriculum their curriculum as well, their didactic curriculum. And so we are really excited for the opportunity to use our didactic curriculum to support training programs where there aren't a lot of neurologists. There's another question about how people who live in rural areas access emergency care. And you know, that's a huge challenge. Many people have to walk for hours or find transportation to get to a healthcare center. As a result, the threshold to seek care, I think, is much higher, and the time to presentation is certainly delayed. There's not really an ambulance system in place. There's no 911 equivalent, and so it is a big challenge. And I think that's another reason we're really excited about our graduates now being posted out to the provincial hospitals, so that people in rural areas are still going to have to travel, but at least they don't have to travel across the country. They can now start accessing these specialists closer to their homes. So are there currently any opportunities for undergraduate students to get involved in the program? We have hosted undergraduate students. I've had undergraduate students the past 2 years that have come out and contributed to our research program. So we've developed, this past summer, there were 2 students from the University of Miami who came and did a survey-based project. The summer before, there was a student from Boston University who came and did a chart review project. He actually got into medical school and is starting as a first-year medical student this year. Argye and Victor, there's a question, you know, working in Zambia and Africa, how does it compare to other countries and regions where we are engaged?
Well, I can tell you what surprised me most is the people in Zambia are just wonderful to work with. Not that they aren't wonderful to work with in other places, but they're just incredibly pleasant and welcoming, and there's they're very happy to have doctors from other places. Actually, the national language is English, although there are many other languages also spoken there. And so I think the openness to both the professionals and the patients themselves to having input from other countries has been exceptional.
Yeah, I have to say something that has been mentioned before, but the family support for the patients, and families being with patients 24 hours and helping them eat, bathing them, changing them, you know, it's really impressive to see, and they're very involved with the care of their loved ones. In terms of the residents, the physicians, and everybody, you know, I think that one of the things that when you travel around the world, you realize is that people are actually more similar than they're different, even coming from different cultures. So it's that is something that is always heartwarming to me when I see that, you know, you can connect with people at the same level, no matter where they're from or what culture they come from. It's really good.
Thank you. We have another question. Can you share a story of a patient or family interaction there which really made an impact on you? I don't know, Argye, if you have one offhand. I certainly could share many, but.
Oh, sorry.
So one of the ones that touched me the most was a young woman who had a thrombus in her heart, a clot in her heart, and that can cause stroke, and it occurred when she was pregnant. So pregnancy is one of the things that can actually cause some clotting. And she had a baby, but also had a very large disabling stroke. And her family had to make some very difficult decisions about how they were going to use their limited finances to pay for her care. So she needed to be on a blood thinner for at least 6 months because of this clot in her heart. And the option then was really warfarin was the only medication at that time. Now they have other choices, but she couldn't afford the blood tests. When you take warfarin, you have to have frequent blood tests to make sure your blood is at the same level of thinning for it to be safe. So you don't want your blood to be too thin or you'll bleed, but you want it to be thin enough that you won't have clots break off from this big clot in the heart and cause more strokes. And so finally our plan was that the nice thing there is they can stay in the hospital as long as they want. The bed is free. And we could keep her there and do frequent blood tests there because the hospital actually pays for things like INR, and figure out what dose of warfarin she would need. And in the United States, you have to continually get tested every month because our diet changes. We may go out to dinner. The amount of vitamin K you eat can really affect your warfarin levels. But there they have a very stable diet. They pretty much eat the same thing every day. So we could, because the family was bringing in her food, we could figure out what dose of warfarin she needed for her diet, and we felt safe that she really only needed a blood test once a year because she wasn't changing her diet or any medications or anything else. And so I thought that was very creative, and it really touched me because here's this young mother, brand new baby, and she was making some slow recovery, but I had hoped that she would not have further strokes because of our intervention.
I think one that comes to mind for me was shortly after I arrived in Zambia. I think it was just a couple weeks after I arrived, I was asked to see a patient by one of the internal medicine residents there, and they said, we're pretty sure this is a psychiatric illness. We're about to discharge her to the psychiatric hospital, but could you just come see her? And I went, and this was a woman who'd lost her husband 4 years prior, and about a year ago started sounding funny when she was talking, then eventually stopped talking, and then eventually stopped walking, and she'd been diagnosed over and over again with depression, and everyone was saying it was a grief response to the loss of her husband. But in examining her, I knew immediately that she actually had ALS, or Lou Gehrig's disease. And so I canceled the discharge to the psychiatric hospital and explained the diagnosis to the woman and her daughter. And she was very at end stages of ALS at that point, and she actually passed away at home 2 weeks later. But her daughter called me after that to say thank you, because we had at least given them an answer and an explanation, and they knew what to expect. And so to have someone call you after you've lost their mother to say thank you, was really, really impactful. I guess one of our participants is using an example, and I'm assuming this is Anna, is using our example of the cancer hospital in Zambia. So they built a cancer hospital in Lusaka, and now are able to provide chemotherapy and radiation. And so she's saying, we are hopeful that we can continue to advance care and maybe even have thrombectomy soon. I have a question about, for context to our neurology residency program, how does one become a physician and then a neurologist in Zambia? So this is a great question. It's a little bit different than here. So graduating high school students in Zambia take a final exam and get a score. And essentially the top 300 score achievers in the country are invited to enroll in the medical school program at the University of Zambia. It's a combination of an undergraduate degree and medical school that takes 7 years. At the end of finishing medical school, they then do a 2-year internship where they spend time in pediatrics and obstetrics and medicine and surgery. And then after that 2 years of internship, they're required to go do at least 2 years in a rural healthcare setting where they are the internist, the pediatrician, the obstetrician, and the surgeon. And after they finish that 2 years, then they can come back and do their postgraduate training or residency. And actually, they're not required to do residency, so that's a big difference. People can continue to practice as sort of a general doctor. And then if they decide to come back and do their residency, they complete 3 years of internal medicine training and then 2 years of neurology training. So we're still kind of in the old British system where neurology is considered a subspecialty of internal medicine. So they do a full medicine residency, and then neurology is a fellowship, sort of. And then how is the program currently funded? So we have several streams of funding. The residents themselves, their salary is all provided through the Ministry of Health. So the Zambian government supports the residents and the training. My support is primarily through M.H.S funding at this point that's funding our research program. And then we do have philanthropic support for our global neurology fellows who come from the US or other settings to complete a 1-year fellowship in global neurology. And we also have other philanthropic support that allows us to support our Zambian residents in their additional endeavors. So for example, some of our graduates have recently come to Hopkins and done subspecialty experiences. So we just had a graduate come and spend 6 weeks with the Movement Disorders Division. We've had several graduates come and spend time with the Neuroimmunology Division. We've had graduates come and spend time with the Stroke Division. And then we also have philanthropic support to allow our residents to be able to attend conferences and present their own research work and get those networking experiences as well. So we have one final question from our audience, and thank you to whoever posed it. What are we most proud of over the last 5 years working in Zambia, or last 6 years working in Zambia? Argye, why don't you start? You've had the opportunity to sort of see it in fits and bursts as you come and go.
I think the graduates themselves are by far the thing that Deanna should be most proud of, that these neurologists who have gone through the training are fabulous neurologists in each of their areas and taking excellent care of people, both in Lusaka and in rural areas, as she mentioned. So I think that's probably what she should be most proud of.
Thank you, Argye. I agree. We have a fantastic team in Zambia, and I think, really seeing neurological care be revolutionized in Zambia and now starting to see the potential for this regional impact of training neurologists that are going to go back to their home countries and hopefully start similar programs is really, really exciting, and I'm particularly proud of that as well. So thank you all for those great questions. I'll turn it back over to Justin.
Well, all I can say is, wow, that was an incredible discussion. Thank you, Victor, Argye, and Deanna. I've learned a lot tonight. I hope our audience has too. And I thank my excellent colleagues for being so generous with your knowledge, and a sincere thanks to all of you for listening and learning with us this evening. As Deanna has shared, all of the good work that has been done over the past 5 years has generated a wonderful momentum, which has led us to this point. This incredible opportunity to revolutionize how we deliver stroke care in an under-resourced setting. You can imagine that our plan to renovate and outfit a dedicated stroke unit and an official home for neurological care, education, and research at UTH in Lusaka has a cost. And we're kicking off tonight a $3.22 million campaign to accomplish this critically important capital project and to execute programmatic investments that will make meaningful improvements in how we treat stroke and other injuries and diseases of the nervous system, not just in Zambia, but in all resource-constrained environments. The budget for this project includes items as foundational as telemetry and cardiac chairs, simple pieces of equipment, to funding for global neurology fellowships, to support travel for Hopkins physicians, nurses, therapists, and others to spend 1 or 2 month rotations training their peers at UTH, and to secure critically important diagnostic equipment, including a particular imaging device that we're going to be demonstrating right here in just a few minutes. You've heard a lot about imaging tonight, and I think it's really important that we show you tonight just what could be done. So I humbly ask that you accept an invitation to have a conversation with Kalen Kopcho or Angel Terrell from our development team. They'll follow up in the near term with a link to the recording of this program, and in the meantime, continue to consider how you might support our efforts through your philanthropy, and who from your network of friends, colleagues, family might also be interested in learning about this critically important work. So once again, many, many thanks for joining us here tonight. If you're able, please stay connected for another 10 minutes or so, in which we'll demonstrate a really important new diagnostic tool, a so-called hyperfine MRI machine, portable and something that could be deployed in the Zambian setting. So thank you all.